We have our lunch and learn, and a big shout out and thank you to TBK Bank. They have continued to sponsor our lunch and learns even through all the pandemic and lunch and learns virtually. So thank you, TBK, for all the support and continuing to sponsor our lunch and learns. So today's topic, deciphering dizziness, potential causes and treatments. Preston Wolf from Ohana Physical Therapy is here to present, and we appreciate you doing this. I told him I stood up the other day from the chair, kind of reclined, watching the football game, stood up really quick, and I was like, whoa. And I thought, I am glad Preston's going to present, so maybe I can figure out what the heck is going on for my, more than usual dizziness. So Preston, thank you so much. I'm going to turn off my video screen so I can take a bite of my Chuck Norris from Birds, and I'll let you share your screen and take it over from here. Thanks.
Awesome. Thank you so much, Jack. Okay, let me see if I can remember how to share my screen. I believe it's that one. Okay, so first of all, thank you all so much for taking the time out of your day to come and learn a little bit about various causes of some dizziness and how we can really address those. So like Jack mentioned, my name is Preston Wolf. I'm a physical therapist at Ohana Physical Therapy. And that's not, there we go. Okay, so first a little bit about me and who exactly is presenting. So I'm originally from the Pacific Northwest, from the great old state of Washington. And I received my undergraduate degree from Whitworth University in 2012 and recently graduated in May from Regis with my doctorate of physical therapy. I actually just moved to Durango in November and have been working at Ohana ever since. And when I'm not spending my time in the clinic, I really enjoy skiing, mountain biking, and spending time with my little dog, Ellie. So some objectives for this presentation. By the end of it, you all should have a general understanding of the anatomy of the vestibular system, be able to list the 4 common causes of dizziness, describe other potential causes of dizziness, and then also explain some of the foundational basis for vestibular rehab. So to start off, let's talk a little bit about the vestibular system. So really the main purpose of the vestibular system is threefold. First of all, is to stabilize our vision during movement. So when you're trying to scold your children and you're staring into their soul while shaking your head no, it's the vestibular system that allows you to stay focused on them. It also really helps with differentiating your own movement from the environment. Best example of this is when you're in a parking lot, you have your foot firmly on the brake, but then you get this feeling of, as you're rolling, that you're rolling backwards when really it's the car next to you that's moving and you stomp on that brake pedal. That is that vestibular system providing that input that you aren't actually moving. And finally, it also plays a huge role in maintaining our balance. And really, it's only one piece of the balance puzzle. So besides the vestibular system, we also really heavily rely on our vision, because if you notice that the horizon is suddenly starting to change, it's a pretty good indicator that you're starting to fall. And additionally, we have proprioception, which is really just a fancy word saying that we have all these little joint sensors within all of our muscles and joints that tells us where exactly our limbs are in space. So when it comes to the vestibular system, there are really 3 main components that are a part of it. There's some sort of sensor, there's a central processor, and then an output. So that sensor is made up of 2 different parts, which is within the inner ear. There's a bony labyrinth that encases a membranous labyrinth. And within this labyrinth are more parts. So we have our semicircular canals here, and those are responsible for detecting rotational movements of your head, such as when you're nodding yes or no. And then also if you're getting up from the bed, rolling over, and that sort of thing. And the way that works is we have a fluid within there that presses on or moves little sensors within it. And then to detect kind of that linear motion, such as going up in an elevator or driving straight along, we have the utricle and saccule. And within those are little crystals called otoconia that are gravity dependent and that provide that input. And all of that information is then processed via the cranial nerve number 8 to the vestibular nuclei and the oculomotor nuclei that are in the brainstem. And from those, they interpret that information and provide a motor output depending on whatever is necessary. So the vestibular ocular reflex allows you to keep your eyes focused on something while you're turning your head. The vestibulospinal reflex allows your muscles to keep you upright. And the vestibulocolic reflex coordinates your neck muscles in order to provide a desired movement. So here's a little bit bigger picture of that vestibular system. So in the blue here is that bony labyrinth, and this orange component here is that membranous labyrinth. So here on the left, this is part of those semicircular canals. So as fluid moves back and forth against this, these little hair cells are what provide the sensory information to the brain. Whereas here on the right, these little purple components are those crystals that I was talking about. And they sit on top of this little membrane that also influences these hair cells that then get transmitted toward the brain. Oh, where'd my pointer go? There we go. So really, before we start talking about the various conditions and their treatments, we should really talk about the principles of neuroplasticity, which neuroplasticity is basically just the way that our brain learns and adapts to various different stimuli. And there are 10 different principles that were proposed. The first one is the classic use it or lose it. But then following up with that, you can also use it and improve it, just like any sort of muscle in the body. If you don't use it, you're going to lose that muscle mass. But if you use it, you can also improve that muscle mass. We also need to have specific stimuli in order for the brain to adapt to it, such as if you want to work on your biceps, you do bicep curls. And it's very similar to the brain. If you want to improve the coordination of your vision, you work on the coordination of your vision. It also requires a high amount of repetition and an intensity that will also provide that benefit. We need to have a good amount of time for these adaptations to occur. So this next one, salience matters. That is just a fancy way of saying it needs to matter to the person. If their goal is they want to improve reading, then it doesn't make sense for them to go out and run a marathon. That's not quite the same principle there. Also, age matters. Younger brains are a lot more ready for adaptation and change. And so with older individuals, some of these plastic changes tend to take a little bit longer. We have transference, so learning one activity can transfer to another, but we also have interference. So one activity can actually hinder the learning of a new ability. So when it comes to vestibular rehab, these are the 4 that really matter the most to us. So we need to have very specific stimuli in order for the brain to relearn what it needs to do. We need to have a high amount of repetition. We need a good intensity that allows the brain to adapt to some of these dizziness error signals. But we also don't want it to be so much that it overwhelms. And also we need to have a good amount of time of practicing these specific exercises in order to achieve the goal that we want. So the first and the most common form of dizziness is benign paroxysmal positional vertigo, or as everybody says, BPPV. And what it is a it's a triggered vertigo or dizziness triggered by specific movements. And really at its core, it's those crystals or those otoconia that have broken off and have actually entered the semicircular canals, making that fluid that's in there more dense. The best way I like to think of this and explain it to people is if you have a big old pot of green chili and you're going and stirring it, you're stirring it really fast. And as soon as you take that spoon out, it's going to keep spinning. And that's really the idea behind BPPV, is in one ear, that fluid keeps spinning, while in the other ear, it is no longer spinning. So we have this disconnect between the two ears that causes that dizziness. And so with the vertical canals, so the anterior and posterior canals, those are triggered by looking overhead, rolling in bed, and also bending forward. Whereas the horizontal canals are most often triggered by head turning, such as when you're checking your mirrors during driving. And so there are a couple factors that really play into how long these symptoms last and how often they come into play. So as we age, it becomes more likely for those crystals to become dislodged and move into the semicircular canals. A history of BPPV also puts you at greater risk for another reoccurrence. For some reason, BPPV is more common in females than it is males. If there's insufficient blood supply to the inner ear, that vertebrobasilar insufficiency, that can also put you at a greater risk. Reduced neck range of motion, so that you're not quite able to get those crystals back into the inner ear or back to their home naturally. That is also a factor. And also reduced activity levels because of fear of dizziness will also prolong those symptoms. And really, there are two different types. So there's those crystals that are free floating in that fluid, which is that canalithiasis. There we go. I can never quite get it right. And then there's also the cupulolithiasis, where those otoconia actually get stuck onto that little sensor that's in those canals. And that creates this continuous feeling of dizziness whenever the individual is in that provoked position. So to test the various canals, there are really three different testing maneuvers. So there's the Dix-Hall pike, which is the most common to test for that posterior canal. There's the deep head hang for that anterior canal, and then the head roll test for the horizontal canals. And so when we perform these as PTs, what we're looking for is involuntary eye movement called nystagmus, and we want to see which direction that nystagmus is going. We also want to make sure that we're documenting how long it takes for that nystagmus and dizziness to come on, and also how long it lasts. So in order to understand nystagmus, I have a little video. And so what you're seeing here is they're in infrared goggles, and the nystagmus is that actual slow drift that you're seeing there. And then there's a corrective saccade to bring it back to the middle. So now they've actually incorporated a little light for some fixation. But as you can see, that nystagmus is still present, although not quite as intense. So in this bottom right-hand corner of the video, you can actually see the individual in that head roll test position. So this is testing the left horizontal canal. And so this is indicative of BPPV in that left ear. So for treatment, for the anterior and posterior canals, we go through the Epley maneuver, and that treats the canalithiasis. For that cupulolithiasis, we do a liberatory maneuver, which involves the therapist stabilizing the head and then very quickly dropping them from one side to the other. And then for the horizontal canal, we have the Lempert maneuver, or more affectionately called the barbecue roll. And as I show you the video, you'll see why it's called the barbecue roll. But first, we'll start off by looking at the Epley maneuver. Okay, well, apparently you guys couldn't hear the video. So basically what they were going through is a series of head movements that really tries to move those crystals back into the part of the inner ear where they belong. And so we hold that position, or each one of those positions, for as long as the patient has dizziness, which is usually around 30 seconds. But the reason why we want to hold it for that entire duration is we don't want to leave any of those crystals in the canal. So then we'll take a look at the barbecue roll. After we have a nice little ad. Okay. So here in the barbecue roll, we start with the affected side, rolled over to that side. And then in a couple seconds, he will actually move his head over towards the unaffected ear. And just like with the Epley maneuver, we really want to hold these positions for as long as possible. So after the dizziness goes away, we roll all the way over so that the head is down. And currently that is where we can stop. But you can also continue rolling until they're all the way back on their back again. And so as you can see, it's affectionately called the barbecue roll because it almost looks like a pig on a spit. And then once you're done, you sit back up and then you retest. So the next most common cause of dizziness is unilateral vestibular hypofunction. And this is usually preceded by a viral infection that causes inflammation of the vestibular nerves. So the symptoms that characterize this are severe rotational vertigo, imbalance, nausea, and then spontaneous nystagmus with horizontal and rotary movement with that fast component or those saccades going away from the affected side. And there are two different types of it. So there's this neuritis where only the vestibular branch of the eighth cranial nerve is affected. Whereas with this labyrinthitis, it affects both branches, with the main difference between the two being hearing loss with labyrinthitis. And really we have compensated versus uncompensated when it comes to patient presentation. So acute compensation happens in a couple days where just sitting normally, we won't have dizziness, but with head movement, that compensation just normally can occur in about a month without physical therapy intervention. Really what we as physical therapists treat is this chronic compensation so that we don't have those patients have this dizziness for several years. And there are various forms of it. So there's habituation, which is performing various movements that will help the brain adapt. There's adaptation, and then there's also substitution, where we actually augment the other two systems, our vision and their proprioception, in order to assist for that lack of vestibular input. So the American Neurological Physical Therapy Association, they put out a clinical practice guideline for treatment of unilateral vestibular hypofunction. And really it comes down to what exactly the patient's main complaint is. So if it's that dizziness and vertigo, that's when we look into the habituation. If we have visual blurring while moving our heads, such as coming back to that example of looking at somebody and shaking their head yes or no, and there's blurriness there, that's when we perform gaze stabilization exercises. If somebody is having falls or is just in general unsteady, that's when we start to look more at their balance and their walking ability. And also, we also just look at improving people's endurance, since aerobic activity actually helps with that neuroplasticity. So the next more common cause of dizziness is Meniere's disease, which is an increase of the hydraulic pressure of the inner ear, which is most often caused from a malabsorption of that fluid. Our body naturally just reabsorbs and remakes that fluid that's within the inner ear. But if there's a problem with actually reuptake of that fluid, it causes this increase of pressure that can then cause dizziness. And there are four key symptoms that we see with Meniere's disease. We have fluctuating hearing loss that is correlated with those increases of pressure. We have that vertigo, tinnitus or ringing in the ears, and oral fullness, which I like to think of or describe to individuals as feeling like your head is underwater or like you have water stuck in your ear. And these symptoms can last anywhere from 30 minutes to 24 hours. And really the feelings of imbalance may persist past those 24 hours. So when it comes to the treatment of Meniere's, rehab is not always necessary. But what we really want to look at is if there's worsening of that vestibular function or continual feelings of off balance, that's when those individuals will benefit most from physical therapy intervention. Otherwise, the main treatment strategy is through medical management and the use of diuretics to help with clearing out of that extra fluid. So finally, another more common cause is concussion. So there are approximately just under 4 million cases in the US annually. So this is a pretty common cause. And these symptoms can be anywhere from minutes to months, with these persistent symptoms being present 10 to 30% of the time. And some of those long-term causes or symptoms may be mood or cognition changes, such as feeling this cognitive or mental fog, sleep disturbances, neck pain, changes in vision, and then those vestibular imbalance changes. And really, it's those last three of neck pain, visual disturbances, and balance changes that we as physical therapists really treat. So some of those visual changes can be impaired smooth pursuits. So smooth pursuit is when your head is fixed and you're simply tracking a movement or an object as it moves through your visual field, or saccades, which is the quick movement of our eyes between various objects. And really, when we are reading a book or anything like that, we're not using those smooth pursuits. Our eyes actually jump from one word to the next. So individuals with a concussion may complain of difficulty with reading, having headaches or dizziness, and that's indicative of those saccades being impaired. We also have impaired vergence, so crossing our eyes or reading anything up close. And then we also have visual motion sensitivity. And the best thing that I can come up with for an example for that is when you're driving in the car and the movement of the trees and other cars going past you, and that causing dizziness. But we also see vestibular changes from this sensory conflict between all of those different balance systems of the vestibular, the vision, and then our somatosensory, or that proprioception, which is in part because of altered central nervous system processing. It tends to be slower following concussion, which causes that sensory conflict. So when it comes to treatment, it's very similar to our unilateral hypofunction. So really taking into account the patient's goals and what exactly they're complaining of and moving forward with that. So if they are getting dizzy with a particular movement, that's when we go into that habituation. If they're having difficulty with staying focused on an object while they're moving their head, that's when we do gaze stabilization. If somebody's having trouble with reading, we perform those saccades with that oculomotor training, balance training if they're having difficulty with balance, and then finally aerobic activity to help supplement that neuroplastic ability of the brain to learn. So some other causes of dizziness. This is not an exhaustive list, but we can have cervicogenic dizziness, so neck pain that is actually causing our dizziness due to altered proprioception or somatosensory information. We have orthostatic hypotension, which, like Jack mentioned he had, which is that feeling of quickly standing up and the brain is not, I should say, the brain has a moment of decreased blood supply, which causes that feeling of dizziness. Other common causes are side effects from medications, anxiety and depression, panic attacks, and finally the big one, stroke. So as we as PTs go through our assessment and initial evaluation of an individual, we want to make sure that we really screen for some of these red flags, such as stroke or panic attacks, side effects, neck pain, and we really want to make sure that we're treating them to the best of our ability. So in conclusion, there are really many different causes of dizziness that can really affect our quality of life, especially if we have this fear of becoming dizzy, then we start to limit the activities that we do. And for most individuals, some of this dizziness can resolve on their own. but we as physical therapists can assist with quicker recovery and also assist those who have some of these prolonged issues that last for several months or sometimes even years. Oh. And finally, thank you all so much again for taking the time out of your day to come and listen to me give a very brief overview of some of the different causes of dizziness and their respective treatments. And now I will open it up to any questions that you all might have.
And if somebody wants to either unmute or put it in the chat, I'll start with a couple of questions. So one, seasickness, I used to never get seasickness. And then one time we went scuba diving years ago, and the way the ocean was moving and the still air, some of the swells, and literally, and I tried focusing out on the horizon, and it just went out. Finally, told my kid, it was very young at the time, I said, dump a glass of cold water over my head, just to kind of break the cycle. Are there, people wear that little wrist thing, or they say take ginger? Are there any things like that, or is this just something that you do through physical therapy to overcome that?
Yeah, so with a lot of those like bracelets and stuff like that, they tend to be more of almost more of like a placebo effect sort of thing. And really the cause of that sort of seasickness and feeling of off balance tends to be tied more to that sensory conflict of your legs are moving, but your vision is stable, especially looking out on the horizon. And then also you don't have that vestibular, or the vestibular system says that you're not necessarily moving. And so that tends to be one of the more common causes of that feeling, and that is something that can be worked on in PT.
And I will point out too, when you're showing the horizontal gaze, that is one of the tests for drunk driving. And the only reason I know that is not because I got pulled over once, but I used to be a test subject for the police department back in my younger days. They needed somebody that would not mind drinking and then be tested. And then I had to be carted home later. But and your eye will twitch if you're depending on how much alcohol you've consumed. That's why they do that little test. So you can't fake it.
No, you can't. No, you can't. Yeah, and I was actually talking to my brother because he's a deputy sheriff, and I was asking him about that same question about, because so many individuals come in with some balance difficulty, and they always joke, well, I'll never pass a DUI test. And so I make sure to let them know that there are other things that they look at besides that to make sure that you're not intoxicated.
Right. And there's a question in the chat. Can you see that one?
Yeah, so the question is, if you had a concussion several years ago, would PT still help? Yes, that will. For personal anecdote, I actually also had a concussion several years ago and never had any sort of follow-up or anything like that. And I had one of my professors while in school help me with some treatment, and it actually helped me improve a lot, especially with some of that feelings of imbalance or difficulty with visual tracking and visual stabilization.
And what about, I have a question. So the older I've gotten, and I love four-wheeling, but the older I've gotten, I sometimes will notice, when you're on some of those trails, the Black Bear Road, whatever it might be, you kind of get that vertigo feeling. You're like, whoa, I'm not sure I like this. Is that something that's caused by an inner ear issue? Or is it just because I'm old?
From what I've read, it's not necessarily an inner ear issue. I'm not entirely sure what causes that feeling itself. My best guess is coming back to some of that like anxiety or the fear of it, that's what causes some of that increased blood pressure and feeling of imbalance.
And that explains it because it's usually like on Black Bear Road. So yeah, I get it.
Yeah.
That makes sense. Quit laughing at me, Colleen. What other questions do people have? None. If somebody wants to reach out to you, what's the best way of getting in touch with you, Preston?
Yeah, I will put my email in the chat. So best way will be to shoot me an email, or you can actually call our clinic directly at, I still don't have the number memorized, but 247-7895. Oh, I didn't send that to everybody. I answered a direct message. Let me try putting that email in again. There we go.
Great. Well, thank you for taking time out of your busy schedule and presenting today, and definitely learned some things. And again, if anybody has any questions, you want to follow up, feel free to reach out to Preston. And yeah, I might be reaching out because figure out some things.
Yeah, there we go. I'll be looking for it.
All right. Well, thank you, everybody. And again, thanks to TBK Bank for sponsoring our Lunch and Learns. Go forth and have I'm going to say, instead of snowdown weekend, have a safe no down weekend, and continue to follow all the protocols. So thank you, everybody, for joining. We'll see you at the next chamber event.
Thank you.